There's a canyon in Arizona carved from the mighty Colorado. Its majesty unrivaled, its tranquility unwavering. Upon completion of his expedition of the Colorado, John Wesley Powell described it as the most sublime spectacle on earth. This majestic canyon pictured here, it ain't it. This canyon is surely a spectacle, but not in the way you probably had in mind. Still doesn't keep people from climbing it, though. But I don't think this guy should be climbing here all alone. In fact, I don't think he even knows what canyon he's in. Meet forgetful Frank Fishbottom. He's got dementia. Unfortunately, he's coming in with pretty severe abdominal pain. He has a known history of constipation, but this has worsened over the last few days, up to the point where he isn't passing any flatus or stool at all, which is probably related to the reason he's experiencing a little abdominal pain. I mean, come on. You can't go that long without blowing off a little, steam and not expect to be uncomfortable. The pain he described as colicky in nature, or like spasms. He's also experiencing new onset nausea and emesis, and the emesis is foul-smelling and brown. Nasty. And a drummer, of course. Why not? This drum reminds us that on physical exam, his abdomen is tympanic and distended, but only minimally tender. You go a couple days without being able to move your bowels or pass gas, your intestines will blow up, and you're gonna have a bad time. And as with anyone who comes in distended and vomiting with inability to pass stool or flatus, you're going to want abdominal x-rays, which he's already done. In this particular case, there happens to be a dilated colon with air fluid levels, a transition point in the left lower quadrant, and a peculiar U-shape to the sigmoid colon. It's described as a coffee bean shape. Maybe that's a clue. A big coffee bean-shaped clue. Aw, poor forgetful Frank. It sounds like he's having a terrible day. What could be causing this? My brain is all twisted up with this case presentation. Wait a minute. Twisted? Oh, something's ringing some bells. Could his bowels be all twisted up? There's a word for that. Volvulus. Volvulus refers to a twisting of a piece of bowel around its mesentery. The colonic mesentery is the single point of attachment to the posterior abdominal wall for certain regions of the colon, with the colon itself being relatively mobile, so it can twist around the mesentery. Sort of like the twisting of this rope, but a lot worse. The twisting of the bowel itself obstructs the lumen, meaning no passage of stool or flatus. Twisting of the mesentery kinks off the blood vessels traveling through it, ending with decreased blood flow to the bowel. No bueno. Since we're dealing with twisting of the mesentery, it makes sense that volvulus occurs most often in segments of the colon with free mesenteric attachments, i.e. segments where the colon is not also fused to the retroperitoneum like the ascending and descending colon. In adults, the sigmoid colon is the most common location, accounting for about 90% of cases, which is why this S-shaped snake is right here next to the twisted bowel. The pathogenesis of sigmoid colon volvulus in adults is thought to involve elongation and distension of the colon, which gives it much more slack to go willy-nilly and twist around. Chronic constipation and dysmotility kind of stretch out the colon, creating a long loop of potentially twistable colon. Age is another risk factor for volvulus, especially in patients pushing 70. Why? Well, this population tends to have had many moons of constipation, with decades of colon stretch creating a big ol' floppy, twistable colon. Another risk factor, which is also common in the elderly, is psychiatric disease, particularly Parkinsonism or dementia. Due to the blockage of the large bowel lumen, patients will develop signs and symptoms of large bowel obstruction, such as, not surprisingly, abdominal pain. Volvulus causes intermittent colicky bursts due to bowel contraction during peristalsis, and as volvulus progresses and leads to ischemia, the abdominal pain becomes constant and severe from the bowel ischemia. Distension also develops quickly as the colon proximal to the obstruction, volvulus in this case, fills with air and intestinal juices. And because all that air is building up, percussion of the distended abdomen of patients with sigmoid volvulus will produce lovely tympanic tones. Due to the obstruction, patients will be unable to pass stool or even flatus. The term for no stool or flatus is obstipation. So, not blowing like the wind shown here in this canyon. More trapped, if you will. Nausea and emesis is a common symptom of any bowel obstruction. But unlike small bowel obstruction, when nausea and emesis occur quickly, in large bowel obstructions, they typically don't occur until very late in the course due to the distal location of the large bowel, i.e., way more distance for foodstuffs to travel backwards with large bowel obstruction. Unfortunately, also due to the distal location of the large bowel, vomiting won't be of foodstuffs, but fecal matter. Just no. Since the clinical presentation of volvulus is basically just the same as normal large bowel obstruction, definitive diagnosis relies on imaging. Surprise, surprise. Though CT is widely available and better for diagnosis, the first step in the workup of a patient with a large bowel obstruction typically will involve an abdominal X-ray. Remember that X-ray description from our clinical case? Let's talk about it. The image will show bowel dilation and air fluid levels, classic for any bowel obstruction, but in the case of volvulus, will also show a dilated U-shaped sigmoid colon, kind of like this upside-down coffee bean shape on this coffee cup by this conveniently located X-ray flag. We'll touch on this more later. If the X-ray isn't quite diagnostic and there are no signs of perforation, such as peritonitis on exam or air under the diaphragm on X-ray, etc., then a barium enema may be performed. The contrast-filled distal rectum and colon will have a visible pinching or narrowing of the colon lumen where the volvulus is located. The sharp tapering and abrupt end of the contrast is known as the bird beak sign, because it kind of looks like a bird beak. Note, don't confuse the bird beak sign on barium enema with the bird beak sign on barium esophagram performed for achalasia. Trust me, patients will not appreciate getting a barium enema to evaluate trouble swallowing. Wrong end. CT of the abdomen is more sensitive and specific for sigmoid volvulus than X-ray, and therefore is the test of choice for diagnosing large bowel volvulus. On CT, expect to see the typical dilation of bowel with a few unique twists. Nice. Whoops there, kitty. Watch your step. You don't want to end up in that whirlpool. Or I guess as a cat, you probably don't want to end up in any whirlpool. A classic finding on CT for any torst, aka twisted organ, is the whirlpool sign. This swirling pattern is formed by IV contrast filling the twisting vasculature, which is radiating from a central entrapped point. If colonic mesentery tissue forms the whirlpool pattern, that's volvulus. To help you remember whirlpool sign on CT, we've sketched in the CT cat here next to a naturally occurring waterfall whirlpool. Well, that definitely seems like it fits our clinical case. So what can we actually do to help poor Frank? He's really not feeling good here, guys. Cases of uncomplicated sigmoid volvulus, i.e. no peritonitis, guarding, perforation, seeing other people but definitely still being together, etc. The volvulus can be detorsed endoscopically. An endoscope is advanced up the rectum and air is slowly insufflated to gently, and I mean gently, inflate and untwist the bowel from within. Low tech, yes, but this technique actually works about 90% of the time. So there we go. That's how we can help forgetful Frank from our clinical case. Let's go grab the colonoscopy and get him all set up. He's gonna feel so much better. Simple detorsion of the volvulus isn't the end of treatment though, Speed Racer. After decompression, partial sigmoid colectomy should be performed to remove some redundant bowel and prevent recurrence because, you never know how bad it'll be next time. If surgery is gonna happen anyways, why not just start with that? The decompression is important to prevent injury to the bowel during surgery, if surgery is performed in the acute setting, or to prevent perforation before surgery can happen. So, cut out a piece of sigmoid, sort of like the S-shaped, very bowel-looking piece of flesh this condor is cutting up. With a scalpel? Don't ask questions. If endoscopic management is unsuccessful, or if there are signs of necrosis or perforation, both of which will lead to peritonitis in your patient, emergency laparotomy should be performed. That finishes up sigmoid volvulus. We fixed up Frankie, but we're only a third of the way done with this sketch. Let's keep going. So, we've established that colonic volvulus requires twisting, which requires a little mobility of the colon for free play. And where else in the colon do you typically find that? The cecum, of course. Cecal volvulus is also possible. though much less common than sigmoid volvulus, especially in adults. Cecal volvulus is more common in children and young adults in their 20s. Why is that? It's estimated that about 10% of the population is born with a cecum that's much more mobile than the average bear. This congenital mobility allows the cecum to twist around its mesentery, leading to the same type of obstruction and vascular occlusion seen in sigmoid volvulus. But don't think that just because you're not born with a mobile cecum, you can't have one. Pregnancy, manipulation of the colon, as with colonoscoping or surgery on the bowel itself, or adhesions from previous abdominal surgery are all associated with development of cecal volvulus. The classic presenting symptoms of cecal volvulus are very similar to sigmoid volvulus and obstruction, including abdominal pain, nausea and vomiting, this time regular foodstuffs, thank God, and inability to pass stool or flatus. Inability to pass stool or flatus, not surprisingly, leads to distension and a tympanic abdomen. That being said, cecal volvuluses, volvuli, whatever, can have variable degrees of presentation, though the general findings still apply. On abdominal X-ray, cecal volvulus may have a dilated, coffee bean-shaped colon in the right lower quadrant. So this time, think of the coffee beans on the cup by the X-ray flag. That's annoying. So there can be a coffee bean sign for both sigmoid and cecal volvulus? A huge hint is the direction that the line in the middle of the coffee bean is pointing. It points to the corner that the volvulus is starting in. So this sketchy X-ray we have is sigmoid since it's pointing to the left lower quadrant. As with sigmoid volvulus, diagnosis of cecal volvulus is pretty much confirmed with the whirlpool sign on CT. While the two conditions have pretty similar presentation and diagnoses, cecal volvulus does differ significantly in treatment. Detorsion with a C-scope? Not really an option. It's too far. Treatment of cecal volvulus is surgery. The only question is, how much surgery? If excess mobility of the colon is limited to the proximal cecum, an ileocecal resection, ileocecectomy, with primary ileocolic anastomosis may be performed. If the runaway colon extends further up the ascending colon, a right hemicolectomy, again with primary anastomosis, please, may be performed. All right, now the last topic to cover is a funny one. With volvulus, it's easy to see where the obstruction comes from. So what if you have a patient with almost all the same symptoms but no discernible source of obstruction? Ogilvie syndrome, also known as colonic pseudoobstruction, is a rare cause of colonic dilation without any mechanical obstruction. The pathogenesis of Ogilvie syndrome remains undefined, though there is a laundry list of associated conditions and medications and maybe causes. Point is, we don't really know. What we do know is that Ogilvie syndrome is more common in patients who are hospitalized, especially due to severe trauma, sepsis, and following major surgery. Dilation in acute colonic pseudoobstruction is much more common in the cecum and proximal right colon, although the entire large bowel can potentially be affected. The hallmark of Ogilvie's is colonic distension without something to blame it on, volvulus, fecalith, tumor, etc., which is why it's so interesting. Patients typically have other signs of large bowel obstruction as well, including abdominal pain or nausea and vomiting. Remember, these patients may be very sick and intubated in the ICU and unable to tell you their symptoms. So with sick patients, have high suspicion for this. Abdominal X-ray with Ogilvie syndrome will typically show moderate to severe dilation of the colon, usually in the cecum and right colon. Diagnosis is made with CT or radiographic images that demonstrate massive colonic dilation without evidence of anatomic obstruction. Treatment of Ogilvie starts conservatively, with measures aimed at preventing further distension. This includes careful observation with serial abdominal X-rays, and even though there's no mechanical obstruction, making the patient NPO. If the bowel fails to recover with conservative treatment and there's a low risk of perforation, i.e. not too dilated, pharmacologic treatment may be attempted with neostigmine, a cholinesterase inhibitor that effectively raises acetylcholine levels. Which makes sense. Raise bowel fuel levels, get things moving, and let the bowel decompress itself via chemical fire projectile flatus. Teensy problem. Excess acetylcholine produces a lot of GI motility. So, as with fireworks, light it, run, and expect an explosion of gas and stool within minutes. It's important to remember that before any medications are given for treatment of ogilvys, that there's absolutely no mechanical or anatomical obstruction resulting in this. The medications stimulate the bowel intensely, and so if there is true obstruction, it'll result in perforation. If pharmacotherapy fails, decompressive colonoscopy can be performed to literally suck the farts out of the colon. Just no. And as with all things surgical, perforation or ischemia and necrosis require an emergency exploratory laparotomy with resection of the affected portions of the bowel. Great job, everyone! We're done! Let's review everything we've covered. Volvulus is the twisting of the bowel around the mesentery. In the colon, there are two typical locations, the cecum and the sigmoid colon. This is because both of these areas are freely mobile around their mesentery compared to the right and left colons that are fused to the retroperitoneum as well as having their mesentery. The sigmoid volvulus is the most common location for volvulus in adults. Sigmoid volvulus is associated with advanced age, chronic constipation, and psychiatric illness. Sigmoid volvulus typically results in symptoms of a large bowel obstruction, presenting with abdominal pain, initially colicky and then progressing to constant and severe pain, abdominal distension and tympany to percussion, obstipation, which is worsening constipation and inability to pass flatus, and maybe even nausea with feculent emesis. Abdominal X-ray may demonstrate markedly dilated colon with a classic coffee bean sign, as well as other signs of obstruction like air fluid levels in the colon. Barium enema may demonstrate a bird beak sign, which is a tapering of the contrast in the distal colon to a sharp point where the volvulus is. CT scan is the most sensitive and specific for sigmoid volvulus and demonstrates a swirl pattern of the twisted mesentery. Initial treatment for sigmoid volvulus is colonoscopic decompression. Semi-elective partial sigmoid colectomy is performed following decompression to prevent recurrence. If colonoscopy is unable to decompress the colon, or if there's any signs of necrosis and perforation, such as peritonitis or sepsis, emergent laparotomy should be performed. Cecal volvulus involves twisting of the cecum. Though similar to sigmoid volvulus, there are a few key differences. First, cecal volvulus is more common in children. Cecal volvulus is also associated with pregnancy, colonoscopic manipulation of the colon, and previous abdominal surgery resulting in adhesions. Cecal volvulus has a relatively similar presentation to sigmoid volvulus, including abdominal pain, initially colicky, and then progressing to constant and severe pain, obstipation, which is worsening constipation and inability to pass flatus, abdominal distension and tympany to percussion, and nausea and emesis, which in the case of cecal volvulus is non-feculent. X-ray may show a coffee bean sign again. The difference is that the line through the middle of the quote coffee bean points to the quadrant that the volvulus is coming from. So in cecal volvulus, the line points to the right lower quadrant, and in sigmoid volvulus, it points to the left lower quadrant. CT scan again shows swirling mesentery. Colonoscopy is not performed for cecal volvulus. Surgery is the treatment of choice. Ileocecectomy is performed for excessive mobility limited to the cecum, whereas right hemicolectomy is performed for more extensive mobility of the right colon. Finally, Ogilvy syndrome, or acute colonic pseudoobstruction, is a condition with the same presentation as a large bowel obstruction. However, no mechanical or anatomical obstruction can be located. Risk factors include trauma, sepsis, and major surgery, particularly cardiac surgery. The dilation is most commonly seen in the cecum and ascending colon, although the whole colon may be involved. Abdominal distension is very common and may be impressive. Other symptoms include nausea, emesis, and abdominal pain. Though in sick, intubated, and sedated patients, abdominal distension and lack of bowel movements may be the only initial sign. X-ray and CT demonstrate colonic dilation without an obvious source of obstruction. Conservative treatment involves bowel rest and serial abdominal X-rays. More aggressive treatment may include neostigmine for colonic motility stimulation or colonic decompression. Finally, if there's perforation or ischemia and necrosis, an emergency laparotomy is required. All right, everyone, grab your poop ponchos. As soon as we get Mr. Forgetful Frankie all set up for his colonoscopy, there's probably going to be a whole big waterworks show of poop. And, well, we're right in the splash zone.